Okay. What do? We usually start our classes around 9:30 to 10 p.m. In between this time, we will start our class. Either we post it or not. It's given in our routine. And of course, we have our, you will find an ID, our Backbenchers family. So family members will post. Family members will post the class time on the given date. And about exams are posted on the same time. And we have rewards for anatomy exams only, but that's for our long course, not in our crash course. But you should give the exam, every exam, because those are highly chosen questions. And I will not say anything extra. I will not start any conversation about anything. I will mention the important topics, show you the ways, explain the basics, and then you start studying. We will start from our book. This is our updated book. You will have the PDF in our drive. The drive access you have, that contains all our notes, all notes, all materials. What are the other materials except notes? Our one-line arrows, our flashcards, important charts for MRCS Part A, everything. And of course, recalls. Of course, recalls. We don't need it now. We will solve some recall before the exam, given date on the routine. Okay. We will start our class now. We will start with our anatomy app. And uh, as we have studied anatomy a long time ago, so we need to revise something. Like some things we have forgot, some minute details. And if we see, okay, guys, I need to stop the sharing a little bit because I can show you my password. Anyway, 1 minute, guys. Filter head neck. Okay, guys, this is our anatomy app. We overview some topics first, then we will go to our notes, what you need to study and what you don't need to study. See, first of all, we need to know what are the parts that are important for MRCS Part A. Other than that, nothing is important. Nothing is important. Only the things I mention, you focus on that. Only the things I say, you study. Otherwise, you will be lost in details. There are a lot of details. This is not an anatomy exam. This is a surgery exam. This is a place called Terion. And first thing you need to know, that is Terion, this place, because this is very thin area and there are 4 bones connecting here: frontal, squamous part of temporal, greater wing of sphenoid, and parietal. These four bones are attached here. And why is this thing important? Because inside it, if we add some arteries, above it, we have temporal arteries. Like these arteries are temporal arteries. These are our temporal arteries. If you give an incision over this area, and remember incision, if you give an incision over this area and it will sprout blood, like a garden pipe. আপনি বাগানে পানি দেওয়ার সময় যেভাবে পানি বের হয় ঠিক ওইভাবে আপনার এখান থেকে ব্লাড বের হওয়া শুরু করবে, and you have to catch it very promptly. These are temporal arteries, remember. But if you hit this area, remember, hit, these bones will break. And inside it we have an artery that is very, very important, that is middle meningeal artery. We have this very important artery here, and this place is very thin. This thin place, if you hit it with anything like a club means golf bat. Club means golf bat. Like a club, a golf bat, you hit it, and that person will have hemorrhage inside the skull. We will talk about those in head neck surgery, but we have to correlate anatomy while starting. This is the first thing I want to mention. Inside the skull, but outside the brain, and dura mater. Inside the skull, but outside the brain and dura. What can we do? We can hide it. We can hide these two. Let's hide this bone, sphenoid. Let's hide this bone too. And we can see this middle meningeal artery. The branches I have not added. See, we have isolated it. This is our middle meningeal artery. The pink one, the red ones, we don't really need those. We hide it. Now, where does it come from? It is a branch from maxillary artery. Remember, we have all those in our notes. It is a branch from maxillary artery, and we can see it that it's originating from maxillary artery here. This is our maxillary artery. And this is our middle meningeal artery. Just to show you the branch. Okay, guys, this is our middle meningeal artery. Let's add some branches of middle meningeal artery. See, these are the branches that are going under this bone, which we have hid earlier. This is the first thing you need to know from neuroanatomy. If we add the brain, we will see it very clearly that it's outside the brain. See, let's go a little bit close, and it's outside the brain, and it's meninges. Meninges is not added here. We don't need it right now. So this is the thing we need to talk about first thing. Then some basic thing about the skull. Remember 3 lines. Let me tell you, remember 3 lines. Remember 3 lines. This line, okay. Okay, this line, above it, remember all the sensation, all the sensory supply of your face is given by trigeminal, and all the motor supply, I'm just giving an overview. We will go in our note and serially describe everything. All the motor supply are given by facial nerve. Okay, we are talking about only sensory here. Above this line, you will have V1. Trigeminal has three branches: ophthalmic, maxillary, mandibular. Ophthalmic is V1, maxillary is V2, mandibular is V3. Remember this line. Above this line, all of the sensory supply, almost all, is from ophthalmic branch. Below this line, almost all, below this line and upper teeth, UT for upper teeth, all of the supplies, all of the sensory supplies, all of the touch, pain and temperature is given by V2, and lower teeth and below is given by V3. This is just a basic thing to remember because we will have a lot of questions from sensory supply of face and this area. Okay, then the next thing I want to tell you about is the brain. For that, we have to hide this bone. We hide this bone too. Okay, before, remember, on the back side of head, you have only one artery that is in occipital area and it's named occipital artery. Just note it. But we hide it right now. We don't need it. We don't need it. We just need the brain because this is our topic. Remember, we are studying surgical anatomy and you don't need all the details of anatomy. This is our external carotid artery branch. We will hide it. We don't need it right now. We hide it. What do we need? We need internal carotid artery. We need internal carotid artery and some details which I will explain you. See, they will ask you about internal carotid artery. See, this is our internal carotid artery. We will talk about it. This is our internal carotid artery. Just see, because after we study, you will be having a lot of difficulty remembering these things. Just see, this is our internal carotid artery. It's entering the brain and it will continue as middle cerebral artery. Just remember the point I tell you. Internal carotid artery, it will continue as middle cerebral artery and it will give a branch that is anterior cerebral artery. Continuation, middle cerebral artery, branch, anterior cerebral artery. Be very careful about it. Then we need to see the pituitary stalk. This is our pituitary and above it we have optic chiasma. Above it we have optic chiasma. These are very close. These are very close. These are very close. Just see what I show you. These all will make sense. These all will make sense later. Why am I showing you? You will know it. This is our pituitary stalk. Remember, it has anterior pituitary and posterior pituitary. They anterior pituitary comes from Rathke's pouch. Rathke's pouch. Posterior pituitary comes from brain. Rathke's pouch in embryologically originated from nasal mucosa, nasal area, and it will ascend upward and become posterior pituitary. Any growth, any tumor, any oma, any oma will compress optic chiasma. Optic chiasma. Just points to show you right now. Then we will go to our library and show you isolated brain due to some, because we need some points about brain. This one, we need to see the cranial nerves. Remember, all the pictures in your books, everywhere, it's given in this way. It's given this way. You must be very clear about the orientation. What is the orientation? This is anterior, this is posterior. Okay, this is anterior and this is posterior. Now we will go close. This is our optic chiasma and we have pituitary sac here. First thing, olfactory. This is our olfactory bulb. And we have these olfactory nerves coming out through cribriform plate of ethmoid above our nose. Cribriform plate of ethmoid. Guys, do not worry about anything at all, because this class is going to be recorded, and the good thing about recorded class is you can hear it or watch it as many times as you want. This is our olfactory bulb. After that, we have, okay guys, 1 minute guys. One minute, guys. Okay. Okay, this is our olfactory bulb. Then this is our optic chiasma. This is our pituitary. And remember, you have to know their exact location. You have to know their exact location. Olfactory, optic, and this is our very important oculomotor. Oculomotor. See, this oculomotor is arising from এক মিনিট guys, join, আপনি join করে ফেলেন। এক মিনিট guys। Okay, so this is our oculomotor nerve. Oculomotor nerve arising above pons. And why is that important? Why is that important? Because if you have a raised intracranial pressure, see, this brain is very complicated, but you don't go into any complication. Whatever I say, just study that. See, you don't need all the lobes. Just remember, this lobe is our temporal lobe, and this place shaped like U. Inside it, inside it, inside it, see, this nerve is very close, very close to this place that is called uncus, UNCUS, very close to temporal lobe. And this area is called uncus. Remember, brain is a closed box. What are we studying? we are studying cranial nerves, and I'm mentioning the important things from each cranial nerve one by showing you their exact location. Olfactory, optic, oculomotor, which is very close to uncus, temporal lobe. And this place is called uncus. Now, brain is a closed box and it's in a liquid that is CSF. If you have a raised intracranial pressure, this brain will be pushed downwards, downwards, and it will press on this oculomotor nerve first. First, it will press on this oculomotor nerve first. First and foremost, it will press this nerve. What happens when it presses this oculomotor nerve? Oculomotor nerve has two kind of fibers. Remember, number one, parasympathetic fiber, which is like this. Parasympathetic fibers arranged inside oculomotor nerve. If we take a cross section, it's arranged like this, and motor fibers are inside like this. So if I get a pressure from outside, first fibers damaged are the parasympathetic fibers. The parasympathetic fibers will get damaged. First thing, any raised ICP will compress oculomotor nerve and parasympathetic fibers will get damaged first. And what happens if our parasympathetic fibers are damaged? We have this oculomotor, the motor component will get damaged, but later. First sign we have is damage of these parasympathetic fibers. For now, just remember parasympathetic fibers constrict our pupil. If the constrictor fibers are damaged, our pupil will be dilated very much. Very much dilated. Very much dilated. This is the mechanism of fixed dilated pupil. Fixed dilated pupil. Fixed dilated pupil in raised ICP. They ask this question. They don't ask that parasympathetic fiber কখন damage হয় or when the sympathetic fibers get damaged. They just ask why unilateral fixed dilated pupil is due to compression of oculomotor nerve from temporal lobe, or they just refer as tentorial herniating. Tentorium cerebelli is herniating. You don't need to know the details, just know the name. Tentorial herniating. We have these in our notes, no problem about that. We will show you definitely. Then they ask another question, that is, what is this nerve? Remember, this is a trigeminal nerve. This is a trigeminal nerve. Guys, stay mute. If I get out of this anatomy app, this will cause problem. This will cause problem to launch the app again. So don't talk. Stay mute. Then olfactory, optic, oculomotor, this is our trochlear. It has a long course, very long course, very long course. I will talk about it. Trigeminal nerve. This is our trigeminal nerve, and this is the motor root. This is the sensory root. Remember, it's situated in pons. Pons. Trigeminal nerve nucleus is in pons. Very important. Where is the nucleus of trigeminal nerve? Pons. Now, they ask this question frequently. This is pons, this is medulla, and this is the pontomedullary junction. What are the nerves that arises from pontomedullary junction? Abducens. Facial. Facial এর সাথে vestibulocochlear. 6, 7, 8. These three nerves, guys, these three nerves arise from pontomedullary junction. This is a straight cut question. They ask it this way. They ask it this way. And you see with your own eyes, with dilated pupil, very much dilated pupil, watch it very closely, that this is our pontomedullary junction. The first nerve arises from pontomedullary junction. It is abducens, then facial, and then vestibulocochlear. Okay, guys, then from our medulla, we have glossopharyngeal, vagus, and spinal accessory. This is our hypoglossal. The final one, number 12. See, and this is a very frequent question. Glossopharyngeal, vagus, spinal accessory. This is our spinal root of spinal accessory, not so important right now. This is our hypoglossal. They ask, where is the nucleus of glossopharyngeal? Of course, in medulla. Where is the nucleus of vagus? Of course, in medulla. Very easy. Now, let's come to the hard questions. When does it get hard? When you add the arteries. Guys, let's talk about the basics now. This is our vertebral artery. Just follow me. You will have everything written in the note. This is our vertebral artery. From two sides, our vertebral artery enters our cervical 6 vertebral transverse process. And we have two circulation in brain, one coming from posterior side vertebral arteries, one coming from anterior side, that is anterior circulation from internal carotid artery, and another from behind from vertebral artery. These vertebral artery will come up to medulla, and in pontomedullary junction, it will become one artery, that is basilar artery, and go up. And this is called vertebro-basilar system. Vertebro-basilar system will come from behind. That's why it will be called posterior circulation. And internal carotid artery and supplying area will call anterior circulation. You need to know the terms. They ask these things. They ask these things in their questions. Now, if we add the artery, we can see those things. We add more. If we add more, this is our basilar artery. And they ask a very simple question. They don't ask circle of Willis. Guys, remember, this is a surgery exam. This is not a medicine exam. They will not ask you about all the type of stroke, this thing, that thing. No, you don't need that. I will tell you what you need and you study those. They don't ask about circle of Willis. Not at all. They will just ask you which of the artery will connect posterior circulation and anterior circulation. Of course, it's in circle of Willis, and that is posterior communicating artery, or this one. We have this posterior cerebral artery coming from basilar artery, and this posterior cerebral artery is connected with this one, or anterior circulation, with posterior communicating artery. I will show you, guys. Just add the arteries and we have it. See, this becomes way more complicated, guys. This is our internal carotid artery, and this is our posterior cerebral artery. This is our posterior communicating artery, and this is our circle of Willis. Of course, this is the circle, but you will not have any question from this circle. No question, guys. No question from circle of Willis. Not important at all. Just forget it. Just forget it. See, let me show you this circle. Posterior cerebral artery, posterior communicating artery, internal carotid artery entering and continuing as middle cerebral artery, giving a branch anterior cerebral artery later. And this is the circle of Willis. Not important at all for MRCS part. They will just ask which one connects anterior circulation to posterior circulation, posterior communicating. And two anterior cerebral arteries, ACA, are connected with each other by anterior communicating artery. Not important at all. Not important at all, guys. And what are the questions they ask? This thing, see, if you have, see, this nerve is very close, guys. This nerve is very close. So if you have a dilatation or aneurysm in this vessel, which nerve will be affected? This is your question for exam. This one, oculomotor nerve. Very simple. If posterior cerebral artery is dilated or you have an aneurysm, an U-shaped area in artery. What is an aneurysm? An U-shaped area in artery. Eta amar banano, that's my invention. But we will talk about aneurysm in our physiology and pathology classes. The pathologies, we know it all. See, if you have a dilatation, abnormal dilatation, it will press oculomotor artery. Oculomotor. See, one by one, we will deal with everyone. Then second question, very important question. If you have, see, this is our vertebral artery. Don't get confused, guys. This is our vertebrobasilar system. This is our basilar, and this is our vertebral artery connecting with each other. Okay. This is our pons. This is our medulla. Just to get oriented, you know. You already know. You are oriented, I guess. Then this is our anterior inferior cerebellar artery. What did we say earlier? What did we see earlier? We just saw posterior cerebral artery. Cerebral. Opore. Up. And below we have cerebellum here. And what did we say? Here is our anterior and here is our posterior. So what will happen if we have an artery that is inferiorly but slightly anterior? We will say it anterior inferior cerebellar artery. And this one is our just to posterior inferior cerebellar artery, anterior inferior cerebellar artery, and posterior inferior cerebellar artery. Ica and Pica. Pica and Ica. What do they ask in this exam? They ask if you have an aneurysm in anterior inferior cerebellar artery, what are the nerves that will be affected? See who are close. Who are close? Guys, abducens. Abducens, nerve number 6. Facial, nerve number 7. Vestibulocochlear, nerve number 8. Okay. Now, another thing. What is this artery? This is posterior inferior cerebellar artery. See, these two are close. These two are close. But these are very close. It's just going in between our glossopharyngeal. Guys, wait a minute. It's just passing in between our glossopharyngeal GP and vagus. Oh. So, and facial and vestibulocochlear are close to facial vestibulocochlear. When we know their function, we will be very clear about everything. Just see the anatomy, what happens, why that happens. See, if we have an aneurysm in pica, posterior inferior cerebellar artery. It can affect nerve number 7, nerve number 8, nerve number 9, nerve number 10, all of them or some of them. It can affect all of them or any of them or some of them. So both AICA and PICA can affect 7 and 8, AICA plus 6, PICA plus 9, 10. AICA plus 6 and for PICA just add 9 and 10. Just add 9 and 10. Okay, guys, then what are the important things I want to know? If we have an aneurysm, it will compress these. If we have a TR in this blood vessel, what will happen? The hemorrhage, these the due to the hemorrhage, we will have problems again due to loss of blood supply. Loss of blood supply. Due to loss of blood supply, these nerves will lose their function. These nerves will lose their function. Which nerves? Facial can lose, vestibulocochlear can lose, glossopharyngeal can lose, vagus can lose. What are their functions? We will talk about that. And of course, cerebellum. Of course, cerebellum will lose its function. What's the primary function? One function you need to remember. If you don't remember all of it, that is balance. Cerebellum controls our balance and proprioception. I will talk about what is proprioception. Proprioception. Proprioception means where is your priojon? Simple as that. Where is your priojon? That means your beloved ones. Where are they? Where is your toe? Where is your tip of tongue? Where is your uh, everything? Okay. Where are those? Their position sense is proprioception. Okay, guys. As we have dealt with all the important things of brain, all the important things have been dealt with. Only thing you will have problems dealing with in brain. Other things we will show you later if needed. Now we go to our note. Guys, see, just study the important things. You don't need all the unimportant things. Those doesn't come in exam at all. See, only one time they asked about when anterior neuropore close, when posterior neuropore close. See, when our brain is developing, we have a tube that is called neural tube. Neural tube is formed by fusion of neural fold. Neural fold will fuse and cause a tube, that is neural tube. And there are two pores, anterior neuropore, posterior neuropore. Not important at all. Just remember it. Just remember it. These two pores are closed. 25th day anterior neuropore, 27th day posterior neuropore. For closing of anterior neuropore, we need folic acid. And that's why every mom at his pregnancy is given folic acid. Just remember this piece of information they sometimes ask. Now, development of brain. We have this tube, we get three dilated part. That one which is most anterior. See, whoever among us is very productive, very fast, we call him progressive. Okay. So the anterior one is called prosencephalon. The middle one, mesencephalon. The posterior one, rear. Remember rear. Those who drive or those who have bike, they have a mirror called rear view mirror. Rear means posterior. Very simple. So the posterior one is called rhombencephalon. The posterior one is called rhombencephalon. Okay. They don't ask any question from that. Sometimes they ask where telencephalon is derived from. Prosencephalon. See, let me tell you. So from pro, remember the first wedding. For in my case, the first wedding I saw on TV is from Royal College, not Royal College, Royal Family Wedding. Royal Family Wedding. I was not born at that time, but I saw the video. Royal Family Wedding of Princess Diana with Prince Charles, now king. Okay, I saw that video. So what did I see? I see Princess Diana was sitting in the middle and telescopes around the world, cameras from around the world is watching her, So in this fast or prosencephalon area, one portion sits in the middle, it does not grow. That is Diana or diencephalon. And one part grows exponentially in every way. That is telencephalon. Like the telescope, everywhere. And in the middle, Diana, that is diencephalon, telencephalon, comes from prosencephalon. Then in the middle, mesencephalon becomes midbrain. Then from the posterior area, you need to know that mitten and myelin. Myelin is medulla. We have L here. Myelin is medulla. And mitten is pons. Mitten is pons. Pons and cerebellum comes from metencephalon and medulla comes from myelencephalon. Just these things they ask from where it comes. And remember, diencephalon has eye cup, central retina, and optic nerve. What is a nerve? A nerve is a collection of fibers, but this nerve is not a true nerve. This is an extension of brain. Optic nerve is an extension of brain. This is not a true nerve. This question doesn't come. Just remember it comes from brain directly. If they ask ever, they do. Sometimes they do. And eye cup is central retina and optic nerve. Very simple. And we have thalamus. Thalamus. Above it, AP, hypo, sub. We have all these thalamus. Epithalamus, hypothalamus, subthalamus. Comes from diencephalon. Okay, these two. You just need to remember what part comes from which area. Then you don't need to know the time. You don't need to know this time. Okay, you don't need to know this time. If you need, I will give you a short note. No worries about that. Then about ventricles, just give a reading. Not so important. Just give a reading. That prosencephalon, mesencephalon, and rhombencephalon comes from fourth ventricle. See, then they ask about ventricles, like what are the connection? Remember, two lateral ventricles, and from there interventricular foramina. One first lateral ventricle, second lateral ventricle. So we have two lateral ventricles. The third ventricle is named as third ventricle. Very simple. And after that, we have fourth ventricle. Very simple. Now, two lateral ventricles will drain into third ventricle. But after third, we don't have two, we have only one. And the connection is also one. So before I was double, now I am single or one, or Banglaয় বললে একা. So একা থেকে aqueduct. So third ventricle থেকে fourth ventricle এর যে connection, we will call it aqueduct, cerebral aqueduct of Sylvius. Fourth ventricle, we have three connections from fourth ventricle. Three connections. Laterally, L for lateral, L for Lashka, foramina Lashka. And in the middle, M for middle, we have Magendie, foramen Magendie. Now, what is the important thing here? If we have an obstruction, this is a downstream. Here we have ependymal cells. Ependymal cells will produce CSF. CSF will flow through this ventricle, and we expect a free flow. If there is any obstruction, this CSF will be collected here and this ventricle will get dilated. They ask this question. What are the questions they ask? Number one question: what is the most common duct to get obstructed? That is number 3 to number 4. The duct is called aqueduct. That's the most common duct to be occluded. See, if this is occluded, CSF will be collected here, CSF will be collected here, and CSF will be collected here too. So all three ventricles will be dilated. And they ask this question, that you have a CT scan and all three ventricles gets dilated. All three ventricles are dilated. All three ventricles are dilated. So where is the obstruction? Is the obstruction? Of course, aqueduct. How? We have a picture here. See, this is the flow. This is the free flow of CSF. If we have an obstruction here, right side interventricular foramen, left side interventricular foramen. If we have an obstruction here, only this will be dilated. If we have an obstruction here, only this will be dilated. If we have an obstruction down here, all three will be dilated. And after that, we have a fourth ventricle. If we have an obstruction under that, below fourth ventricle, in central canal, then all four will be dilated. Simple and easy. This is nothing. This is just a content of CSF. Just remember the amount. They don't ask amount. They just ask RBC. RBC are absent. There will be no RBC. There will be no RBC. Just remember this statement. Then we will talk about foramens in the brain. What are the important foramens? First important foramen you need to know is up here, this one, and down here, this one. Why? Let me tell you why. We need to know what comes from superior orbital fissure, or what traverses from superior orbital fissure, SOF. And what do we need to know? Near it, we have optic canal. See, we have here V1. Three, 4, 5 serially. We have here, we just write superior orbital fissure, SOF. It's a 3 word. We just write 3, 4, 5. Okay. See, oculomotor, trochlear, trigeminal. Which branch of trigeminal? Number 1, ophthalmic. Now, see, from our start days of medical college, what did we do? We memorized in serial: olfactory, optic, oculomotor, trochlear, trigeminal. So when this is an exam time and you have immense pressure, and you will see these are very easy to distract you. If we just add number 2 here, if we just add number 2 here, you will be very distracted. How? Optic, oculomotor, trochlear, trigeminal. See, you will get distracted. Either optic nerve was there in superior orbital fissure or not. Remember, optic nerve was never there. Optic nerve has its own canal, that is optic canal. That is optic canal. That's why this is very important, and a lot of times they give this in exam and people forget. Everyone forgets and makes this easy and silly mistake that optic nerve does not go inside superior orbital fissure. It goes only inside optic canal with ophthalmic artery when ophthalmic vein is in superior orbital fissure. So be very careful. First two foramen you need to know is these two, and second one you need to know is this one. Here we have the same case, that jugular foramen has everything, not everything, like good things, 9, 10, 11, and they just add 12 with it. They just add 12 with it. What is that? See, if we say glossopharyngeal, vagus, spinal accessory, hypoglossal, these are in serial, and we forget that these three enters into jugular foramen, comes out. Remember, it comes out through jugular foramen, and hypoglossal nerve has its own canal, that is hypoglossal canal. Very important and very silly mistake people make with these two foramens. Then which foramen you need to know is, see, you don't need all the foramens. Okay, you don't need just the one I say according to importance. Foramen spinosum, middle meningeal artery, which we have told you. Middle meningeal artery is a branch of maxillary artery. Maxillary artery is a branch of external carotid artery. We will talk about those later. Now, foramen spinosum, we have middle meningeal artery. What do they ask? They ask a person got hit by a club or got hit at the side of head. Now he has unilateral fixed dilated pupil. What happened? He has a hematoma. A hematoma, collection of blood outside the brain and dura, most commonly outside the brain and dura, and that hematoma is compressing the brain, and that brain is herniating and compressing oculomotor nerve parasympathetic fibers. That's why we are getting a dilated pupil. So they will ask a unilateral fixed dilated pupil after a violent blow at side of head. Which artery is responsible? Remember, always, it's middle meningeal artery. First question, which artery is responsible? Second question, if you do a post-mortem, which artery you will find lacerated? You will find middle meningeal artery lacerated. Third question, if you find a fixed dilated pupil, what's the origin of responsible artery? Maxillary artery. These are exact questions, same questions they will ask you in the exam, and you will have the same question in your exam with the same answers. Now, then we talk about another, and they ask that this responsible artery enters brain, that doesn't come out. Be very careful which one enter, which one comes out. Remember, nerves come out through a foramen. Artery will enter through a foramen. Vein will come out. Now, it will enter in brain with foramen spinosum. Then, foramen lacerum, very important. Very important. Remember, foramen lacerum and carotid canal. Carotid canal. See, internal carotid artery enters the brain, enters the carotid canal with foramen lacerum. It just enters with foramen lacerum. Enter. But this is the content of carotid canal. Content of carotid canal. Content of carotid canal. Then, this one is your carotid canal. Then, petrotympanic fissure. We will talk about that. And this thing, no one, how do I know? I will not tell you how I know. No one gave any importance in it. I told you before September exam, again and again, every time I told you about facial nerve, that petrotympanic fissure, and this September exam, this came, guys, and my people answered it correctly. 100%. No, it's not like no one except them answered correctly, but all of them answered this correctly. Like if you know that which one, if you follow these classes and mark all these things correctly, you will have the time to answer complicated questions and think about those. I will create the basics. No worries about that. See, petrotympanic fissure, chorda tympani, branch of facial nerve. Very important. Chorda tympani, branch of facial nerve. Stylomastoid foramen, we will talk about it. It's very easy. Facial nerve. Like those who যারা একটু স্টাইল করে, যারা একটু ছোটবেলা থেকে আমরা যখন স্কুলে ছিলাম, তারা কি করতো? তারা ফেসিয়াল করতো, ছেলেরা আর কি, আমি বলতে যাচ্ছি। এমনি মানুষ ফেসিয়াল করতেই পারে, খুবই ভালো। সো stylomastoid foramen holds facial nerve. Facial nerve comes out through stylomastoid foramen. Then about foramen, which one? Foramen ovale and foramen rotundum. Foramen ovale and foramen rotundum, you don't need any more foramens. Foramen rotundum, see, max pro or Max Pro. I just remembered Max Pro because that was a very favorite medication for me because everyone has gastric problems. Anyway, everyone asks for Max Pro. So Max is connected with Pro. Okay. So maxillary nerve is connected with rotundum. From Pro, we get protundum. I used to study protundum because it's an MCQ exam and you just have to know it. You just have to, আপনার just চিনতে হবে। So আপনি চিনতে পারলেই হইলো। So I used to spell it protundum, not rotundum. I used to say it protundum because this is not a viva, not important at all. Foramen ovale, very important. I will talk about that. Bas, you don't need anything more. All these foramens are written here. Foramen ovale, OVALE, very easy. Spinosum, you already know. This is after eating pan, Amitabh Bachchan is, his head is spinning, and the exact place he is holding his head is the place for middle meningeal artery laceration. Middle meningeal artery laceration, and here we have pterion. Sorry, this P has become, this is pterion. This is the place you get hit, and you get a spin of head, spinning head. So spinosum, middle meningeal artery, branch of maxillary artery. Then we have written down all the important and excluded those that are not important. Okay, foramen magnum, not important, no one knows. And we have foramen rotundum, like 14 pro max. Okay, this is our foramen rotundum, very important. Every year this question comes. You can just, these pictures are just for seeing, there is nothing important here. Then points worth remembering, these are just some point, you know it already, like in first years or other times you have studied it, so you can just give a reading, not important at all. Then sympathetic ganglions and parasympathetic ganglions. Guys, what are ganglions? Ganglions are nothing, just a gang of neuronal cells where some cells end and some cells start. Okay, like a circuit, like a connection, like a switch, or whatever you say it. This is just a dilated area because we have neuronal cell bodies or nucleuses here. That's why we have some dilated area. These are ganglions. Now, the ganglions that deals with parasympathetic system are parasympathetic ganglions. The ganglions that deals with sympathetic nerve or sympathetic neuronal cells are called sympathetic ganglion. Very easy and simple. You will know these names after we have studied all the topic. So don't worry about that. You don't need to study it now. Not in isolated way. Let's start the nerves. Only thing you need to know from olfactory nerve that is goes through from cribriform plate of ethmoid bone. Common cause of injury is base of the skull fracture. Now, how do we use this information? Number one, questions from olfactory nerve. See, number one question they will ask: a person came to emergency department with anosmia. They will directly say that the person is having anosmia plus some material, like some material, watery material is leaking through his nose. What are the questions you will get from this stem or this kind of stem? You will just focus on anosmia and these watery material. They can ask, what will you test? What's the name of the test? What's the test to do to know if this is CSF? Remember, beta 2 transferrin assay. You don't need to remember it now. We have it in physiology and our short notes, one lines to revise. So you don't need anything more than this piece of information. Number two, they will ask why anosmia is happening because of breakdown of cribriform plate of ethmoid bone. Because these olfactory nerves come out through cribriform plate of ethmoid bone. If you remember the nerve I have shown you earlier, this cribriform plate of ethmoid bone has been broken down. Then this is the base of the skull. They will ask you, what are the other signs of base of the skull? This year, this question came, this September. And every neuroanatomy class, if you check my January neuroanatomy class, I have told them this too. Perioral, sorry guys, periorbital edema. Periorbital Aduro. Let me tell you, like periorbital, ever seen a panda or Kung Fu Panda? Remember Kung Fu Panda? Kung Fu Panda, if you see the eye, you will see that blackish area around the eye, black. And this is called panda eye or raccoon eye. And battle sign. What is a battle sign? Like, what do we say if someone is irritating you too much? কানের নিচে একটা লাগাইলে ঠিক হয়ে যাবে. Very simple as that. So কানের নিচে আপনার কালো হয়ে যাবে. কানের নিচে কালো মানে over mastoid area you will have blackish area over mastoid. That is called battle sign. Just remember these two things. Now let's talk about optic nerve. Visual related question. They will ask you visual related question from optic nerve. Not so much question. I will tell you which question. Enters via optic canal holds optic nerve, ophthalmic artery, sympathetic nerve fiber. Remember, sympathetic nerve fiber all over your body is on your arteries. Why? When we will describe our sympathetic system, you will know it more. Visual pathway question, let me explain you a little bit, as we have studied it a long time ago. So we need an extra, we have a short class about it. We will upload that. We will upload that. Otherwise, it will take a lot of time. Just remember, for now, just remember homonymous hemianopia. Homonymous hemianopia. Okay, let me explain. This is our right eye. This is our left eye. This is our right eye. The things we see from right eye, things we see from left eye. Now, if we divide it in two parts, this is our right side of right eye. This is our left side of right eye. The left side we see. The left side we see with our right eye. Okay, same thing. Now you will understand. See, okay, let me make it this way. Right side, left side. We see from our right eye. This is our left eye, and right side and left side we see from our left eye. Very easy, guys. See, this is our nasal side again, and this is our temporal side. Don't bother about it. I'm here. You will understand everything. Let's make our right eye a little bit bigger. Now, what happens? What happens? This left side we can see from this side retina, and this left side we can see from this side of my retina. Okay, here is our retina, and optic nerve coming from this side is like this. It comes, and then here is our chiasma, and it will go this way. From left eye, we see our left side with this side of retina, and optic nerve coming from here will go directly this way. Okay, this is our optic nerve, this is our chiasma, this is our optic tract, and here we have Edinger-Westphal nucleus. After that, we will have radiation like this, which we call optic radiation. Okay, guys. So what happens? What happens? From this side, we will see right side of this eye. Let me make it this color. Okay, from this side, light will come here, and optic nerve will take the information, and it will cross directly and go to opposite right eye. And from this side, দেখেন, রাইট আইয়ের রাইট সাইড থেকে, রাইট আই এর রাইট সাইড থেকে যে আলোটা আমার চোখে আসছে সেটা আসছে এখানে, এবং এখান থেকে আমার অপটিক নার্ভ সরাসরি ক্রস করে চলে আসবে এই পাশে। আবার লেফট আই, এই যে রাইট সাইড থেকে যে আলোটা আসছে সেটা আসবে এই সাইডের রেটিনাতে, এবং this retina will give information to our optic nerve here, and optic nerve from outside will not cross and go to here, to our Edinger-Westphal nucleus, and we will have a radiation like this. So this is our optic nerve, this is our optic chiasma, and this is our optic tract, and this is our optic radiation. Now, what happens? What happens if we have a damage? Okay, let me say we can't see this side. Let me say we can't see right side with right eye. What happens? Let's see. Information goes from where to here. If we follow, if we follow the light, let's follow the light. If we follow the light, we can see the light comes here first, then it travels along this way, and goes to opposite side of optic tract. Then same thing, if we can't see the right side with left eye, right visual field, if we are black here, if we can't see this side, if we follow, we can see it's going at the same place. It's going at the same place of optic tract. So if we forget others, let us see what we get. We just erased all other and kept only the two fibers involved. See, we can't see right side, half of right side with right eye. We can't see half of right side with left eye. These two looks similar. And whenever two things are similar, we call it homo. And we can't see, that is termed in medical term is anopia. Now this anopia or not seeing is not complete. It's half not see. Half not see. That means it's a hemianopia. It's a hemianopia. And this hemianopia is similar on both eyes. Like with right eye, we can't see the right half, and with left eye, we can't see. In case of left eye too, we can't see the right half. So this hemianopia is similar or homonymous. This is called homonymous hemianopia, and the problem here is in opposite side of optic tract, because if we have a damage here, only in this case we will have information coming from right side not getting to visual cortex. Information coming from right side not getting to visual cortex. Information coming from the right side from left eye not getting to visual cortex, because these two, if we have right side hemianopia, we see the left side optic tract is damaged. This question comes in exam. Or optic radiation. It's a radiation. Radiation means band. 1 band, 2 band, 3 band, or all of the optic radiation. All of the optic radiation. Purata optic radiation is involved, guys. Total optic radiation is involved. They will ask you question. If you have, now you know, if you follow through, you know that if we have right homonymous hemianopia, right homonymous hemianopia, Anopia, we have a damage in left optic tract or total left optic radiation, not some part. It has a lot of band, this band, that band, Mayer's loop, that loop, no loop, Mayer's loop. See, this is a radiation, this is a loop. Simple as that. This is one, this is two, this is another, and one is called Mayer's loop. So, not important at all. Just forget it. If any loop mentioned, that is not the damaged area. Damaged area is total optic radiation, total, or optic tract. Optic tract. And this tract spans, tract and radiation spans around parietal lobe, then temporal lobe, and reaches visual cortex in occipital lobe. Visual cortex in occipital lobe. They will ask simple question from here. Homonymous hemianopia, where is the lesion? Optic tract or whole optic radiation? Which side? Opposite side. They will ask homonymous hemianopia, where is the problem? Optic tract or optic radiation. And which lobe of brain? Parietal lobe. And which artery can cause that? Two arteries can cause that. Middle cerebral artery or posterior cerebral artery. Okay. Both can cause homonymous hemianopia. If both, because it spans from here. Okay, I will tell you about these things. No worries. Right now, we just deal with hemianopia. Homonymous quadrantopia. Quadrantopia, very easy, not so important. Just remember inferior quadrantopia, like 1/4 is, I can't see 1/4. I can't see 1/4. Optic radiation problem or parietal tumor or superior branch of middle cerebral artery occlusion. Very simple. Just remember it. PITS. Parietal inferior quadrantopia, temporal superior quadrantopia. They will give you direct question. A person is having quadrantopia. Where is the problem? Okay. Then optic chiasma, very important. I have shown you where is the pituitary gland. If it gets enlarged, what happens? If it get enlarged, it will compress this chiasma and see, compress only the fiber that is crossing. See, here is the crossing, outside go out, outside go out. So only the crossing will be hampered. And what's wrong if that happens? We don't see inside. We don't see from light. We don't see the light coming to this side. See, then this will be presented like this. And we don't see the light coming from this side. So this will be presented as this. See, these two looks kind of similar, but it's a mirror image. Why? Because here right side I can't see, here left side I can't see. This is right, this is left. Or if we say here outside or temporal side I can't see, and here also temporal side I can't see. So this makes more sense and makes understanding easy if we say it by temporal hemianopia. Okay, guys, that's why if the chiasma is compressed, we have bitemporal hemianopia. Simple and clear. You don't need any explanation or any more details for it. These things about acromegaly. See, see, this used to come previously, but right now, this year, last year didn't came at all. So you can just give a reading. If needed, I will describe this later. Not so important. And anopia or vision loss in one eye. optic nerve. Very understandable. See, if this side is gone, optic nerve, only this eye will lose vision. Or if this visual cortex is gone, what happens? See the difference. See the difference, guys. This visual cortex receives information from this side of eye and this side from eye. So what do we have? Tell me this question. What do we have then? If this visual cortex is gone, we have hemianopia, and this hemianopia looks same. So homonymous hemianopia. Very simple. They will just ask you that. Then visual field defect, you can give a reading. You will understand it very clearly after you give some attention to this. Now let's talk about oculomotor nerve. Very, very important. Before that, I'll be taking a 5-minute break, guys. Guys, I'll be starting after 5 minutes, a little break. And this class is going to be long, guys, because anatomy we need to describe, or otherwise you will not understand. Hello, guys. I'm back now. Probably your brain will stop working after 1 to 2 hours, but no worries about that. I will simplify things, and I recommend you watch it half, 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 like this. Like if you have a 3 day gap, you watch it 1 hour, then study, then you watch it 1 hour. Like after first watch, don't just passive watch. Take notes. Take notes on our books, because if you take some time to understand, your memory will last longer. And why is that important? Because in your question, you will not have straightforward questions. You will have this thing, that thing. এই লোক বাজারে গেছে, শিং মাছ কিনছে, শিং মাছ হাতে গুতা দিছে, সেই গুতা লাগছে ফ্লেক্সর ক্রিজের থেকে একটু ডিস্টালি. Now he is not having sensation in last 3 and 2 fingers, but that's not a problem. He is having a headache. And what's the cause of headache? This will be your question. So be very careful about the basics. These are very important. If you know these things very well, you will not get distracted with the shing match, and you will not get distracted with the bajar. So I will not, because I value time very much. I don't have much time, so I don't talk much. I don't talk to anyone. I just take classes. Okay, I have my communication team. They will deal with you. Any problem, you text them. And I have family members, Backbenchers family. They will answer all of your questions and queries. And about your questions related to studies, I will answer them whenever I'm free. Usually I respond at 7 to 9 p.m. every day. Every day I'll be available on Telegram. Not a problem, guys. I'll be there for you. Now, thing is that oculomotor nerve is very important. Every year question comes from here, and I will tell you the specific questions they ask. Specific ones, and only those questions you need to know. For that, you need some basics. And what are the basics you need to know? That one, like I said that if oculomotor nerve, we take a cross section, the parasympathetic fibers are arranged on top, and motor fibers, because it's oculomotor. What does motor fibers do? Motor fibers connect to all your extra ocular muscles except superior oblique and lateral rectus. I will talk about that. But main important function is parasympathetic function for this exam. They don't ask much about these things because Royal College has another exam for ophthalmology. The way is different. So they don't ask you about extraocular muscle at all. Just minimum question, 1 or 2. Now, this thing is very important because parasympathetic supply comes from Edinger-Westphal nucleus. Nucleus of Edinger-Westphal. Just know the name. And they will go to sphincter or constrictor pupillae. Final destination is constrictor pupillae. Let me tell you from the start. Brain, oculomotor nerve, ciliary ganglion. Simplified, guys, simplified. Ciliary ganglion. From ciliary ganglion, short ciliary nerve to sphincter or constrictor pupillae. Sphincter or constrictor pupillae. So remember, everywhere in your body, you just need to know 2 organs. One, pupil, another, bladder. Everywhere there is a sympathetic supply, there is a parasympathetic supply. There is a balance between these two. Anywhere, if there is a parasympathetic supply, there is a sympathetic supply too. Anywhere. And you just need to remember 2 organs. This, your pupil, parasympathetic supply, sympathetic supply. Your bladder, parasympathetic supply, sympathetic supply. Now, what does parasympathetic supply do? Parasympathetic supply in your pupil, it will constrict. Sympathetic will dilate. Okay. In bladder, in your bladder, parasympathetic supply will constrict, sympathetic will relax. What? Detrusor muscle. Detrusor muscle. Remember detrusor muscle. Now, there is a balance. This is the balance. Nikti, whatever you said. Now, if any of the fiber is damaged, the balance is lost. What happens? What happens? Like, এখানের ভার কমে গেছে, তাহলে এটা will go up. So, this is the opposition of this one. This is the opposition of this one. There is no opposition. No opposition. If parasympathetic is damaged, no opposition from parasympathetic. So sympathetic will work without any opposition. And they tell you in your paper that unopposed, that means unopposed sympathetic supply. Unopposed sympathetic supply. Unopposed sympathetic supply. What happens to unopposed? If anywhere there is unopposed sympathetic supply, your pupil will be dilated very much, because there is no opposition from parasympathetic to control the dilatation. So if your pupil is fixed and dilated, they will ask you, what's the problem? The problem is pupil fixed and dilated. What are the questions related to it asked in MRCS Part-A exam? Number 1 question: who is responsible? Oculomotor nerve. Oculomotor damage. Number 2, what's the mechanism happening here? Unopposed. আপনি যখন আমাদের পরীক্ষা দিবেন একদম ক্লিয়ার হয়ে যাবে সব, কোনো প্রবলেম নাই। Parasympathetic, unopposed sympathetic action. Now, what happens if there is unopposed parasympathetic action? Very simple. Your pupil will be very much constricted. Pinpoint pupil. Pinpoint pupil. And about bladder, we will talk about that later. Very simple. You know what is unopposed parasympathetic and unopposed. Here, the important word is unopposed. Don't get confused by it. Unopposed sympathetic action is fixed, dilated pupil. Reason? Oculomotor damage. Very simple. Now, there is a simple rule about constriction and dilatation. See, guys, ciliary ganglion, short ciliary nerve, constrictor or sphincter pupillae, it's a parasympathetic. Para means problem. Anyone gives you a problem, you constrict from her. And most of the time, it's our wives. I don't know, maybe. I don't know. Now, and anywhere you get some sympathy, you get some love. What do? You dilate, like 6 feet dilatation, social distancing, like the signature pose of our beloved Shah Rukh Khan. Okay, guys. So this is dilatation. This is sympathy. So sympathetic will dilate your pupil, and parasympathetic, para dile apni constrict hoben from that person. So parasympathetic will constrict your pupil, and you have to know the serial. What is that? Edinger-Westphal nucleus gives oculomotor nerve some parasympathetic fiber that take it and give it to ciliary ganglion. Ciliary ganglion gives it to short ciliary nerve, and short ciliary nerve gives it to sphincter pupillae. And dilatation, long ciliary nerve. Long ciliary nerve, you need to know nothing about it. It's from stellate ganglion. This is the ganglion you need to know. Stellate ganglion. Stellate ganglion will give some fibers through long ciliary nerve from traveling over internal carotid artery, and these fibers will go to dilator pupillae. Dilator pupillae. They will ask you this question in exam over and over and over again. Here we have written it down. Preganglionic, this is the ganglion, ciliary ganglion. The fibers before it, preganglionic fibers. The fibers after it, postganglionic fibers. Sphincter pupillae via ciliary ganglion. Okay. Accommodation of lens, you don't need it. Forget it. See, this question is the question you will be asked. Now, oculomotor nerve compression. I have shown you that posterior communicating artery. Remember this one, posterior communicating artery and posterior cerebral artery. That was very clear, and oculomotor was arising from here, and any dilatation or any aneurysm can compress this oculomotor nerve. Remember these two arteries, this one not important, forget it. Raised ICP, you know it. Tumor in sella trucica, not important right now, forget it. Guys, let's talk about ptosis. Forget about squint. They don't ask anything about squint. I will tell you, but they don't ask any question from it. Just remember what happens when oculomotor nerve gets injured. Number one, dilatation of pupil due to unopposed action of dilator pupillae supplied by sympathetic fiber in long ciliary nerve branch of nasociliary nerve. Then what happens? Ptosis. Ptosis is very important. Just remember your levator palpebrae superioris, LPS. Same thing. It has both sympathetic and parasympathetic both supply. Any of the fiber is damaged, your eyelid will fall and you will look like you will be looking like you can't pull your eyelid up. That is ptosis. That is ptosis. Generally seen in people who take marijuana. Okay. Because of levator palpebrae superioris paralysis. If sympathetic damage, you will have ptosis. If parasympathetic damage, you will have ptosis too. Now, how do you differentiate if it's sympathetic damage or parasympathetic damage? Is to look at the pupil. Remember ptosis. If we have meiosis with it, that means para is working. So, damage is in sympathetic. Whenever with ptosis, you see fixed, dilated pupil. Remember, sympathy is on, so no para. Parasympathetic is damaged. Very simple. So if you find ptosis in your question, remember if meiosis is present, sympathetic is damaged. Very simple. And most commonly, they give you one syndrome, that is Horner syndrome. You will have ptosis, meiosis. The moment I have said meiosis, you know it's a sympathetic damage. And what is the ganglion? Stellate ganglion is involved. Stellate ganglion is involved. And where is it? It's near your cervical region, which can be compressed by apical lung tumor. I will talk about those. No worries about that. Apical lung tumor. We will talk about that later. Now, you just need to know this thing, dilator pupillae. Then squint, divergence. You don't need squint. They don't ask about squint. Remember extraocular muscles. Remember superior oblique. What did we study? SO4 in our previous years. Now I will introduce you to another method. That is, what is the fourth letter in alphabet or alphabetical letter? A, B, C, D. Remember, not SO4, but SOD. D for what? D for downwards. D for downwards. D for downwards. If This is our nose, that means medial side, and this is our lateral side in front of us. And you draw an eyeball and you write SOD here. Your eyes will be pulled D for downwards, laterally. Where did we get D from our letters? Which number letter? Fourth letter, that is D. So we get downward laterally. Your eyeball will go downward and laterally if superior oblique is working. Very simple. If superior oblique is working, your eyeball will go downwards and laterally. Simple and easy. Do not complicate it. And it's supplied by fourth nerve, that is trochlear. Very simple. Then lateral rectus, easier. Lateral rectus, more easy. It will pull your eyes directly laterally. And it's applied by abducens. And what is a squint? When one of your extraocular muscles are not working, like if lateral rectus is damaged, what happens? Your eyeball will be on medial side. Medial side, that is adducted eye. Adducted eye. Adduct means daka. Adduct means add. Add. Add to nose. Okay. It will go medially and we call it adducted eye. We call it adducted eye. So if we have two eyes like this and one is here, that means straight here, that means an adducted eye. And this eye is good. Normally, when we are looking in front on the mirror, adducted eye is a sign of lateral rectus damage. That means sixth nerve palsy. And this is a squint because two eyeballs are in two places. And what is a diplopia? Like if this eye is making image here, this eye will make image here. So we will see two objects pashapashi, vertically. So it will horizontally, guys. Vertically means soja shuji. Sorry, guys. Forgive me. Horizontally. Two objects laterally, horizontally. So we have horizontal diplopia or HD picture. Sorry, guys. HD picture. So HD picture we find in horizontal diplopia in lateral rectus paralysis. How can this be presented as questions? We have already presented, we have our questions prepared for you. Now, thing is that how? Whenever this person tries to look something that is here, he can't. He can't. As our sixth nerve is paralysis, but he will try. So what happens? His eye will be pulled by superior oblique because that's working, and eyeball can come up to here. That means laterally downwards. Or inferior oblique can pull it here and can take up to here, but not up to this point. Not up to this point. এখানে আসতে পারবে না. Just এই পর্যন্ত, up to this point or up to this point for inferior oblique. Okay. So superior oblique will pull eye downwards laterally. Inferior oblique will pull eye upwards laterally. Very simple. Very simple. Any of the scenarios you will find. Now, another scenario. That is, if we have this eye and we are good, but our inferior oblique pulls this eye here normally. Now, Now our inferior oblique is paralyzed. Paralyzed. What will happen? If this is our right eye, this is our left eye. Now, if we need to climb stairs, what will happen? We can see. চোখের কোনা দিয়ে আমরা সিঁড়ির আশেপাশে দেখতে পাবো। এখন যখন আমরা climb stairs or climb downstairs, যদি আপনি ডাউনস্টেয়ার্স যেতে চান সিঁড়ি দিয়ে নিচে দিয়ে, তাহলে আপনার চোখের এদিকে আসতে হবে। এদিকে আসার জন্য হোয়াট ডু ইউ নিড? ইনফিরিয়র অবলিক। ভেরি সিম্পল। বাট আওয়ার ইনফিরিয়র অবলিক ইফ প্যারালাইজড, যদি প্যারালাইজড হয়ে থাকে, যখনই আপনি এদিকে তাকাতে চাবেন, সরি গাইস, এক মিনিট। See, whenever we want to go downstairs, what will happen? Downstairs we need to see here. চোখের কোনা দিয়ে আমাদেরকে ডাউনওয়ার্ডস ল্যাটারালি দেখতে হবে, এন্ড ডাউনওয়ার্ডস ল্যাটারালি দেখার জন্য আমাদের প্রয়োজন সুপিরিয়র অবলিক। ভেরি সিম্পল, ভেরি সিম্পল। আমি ইনফিরিয়র অবলিক বলে ফেলেছি। নাও ইনফিরিয়র অবলিক কেন বলেছি তার কারণ আছে। যখনই আপনি এদিকে তাকাতে চাবেন, যদি এটা প্যারালাইজড হয়ে থাকে, তাহলে কি হবে? যখন আপনি এদিকে তাকাতে চাবেন, আমার ইনফিরিয়র অবলিক তো ভালো আছে, সো এটা যেহেতু সুপিরিয়র অবলিকের অপোজিং মাসল, ও কি করবে? ও ওকে উল্টা টান দিয়ে দিবে। তখন আই উইল ড্রিফট। ড্রিফট কোন দিকে? আপওয়ার্ডস। আপনি ল্যাটারালি যাইতে চাচ্ছেন, ল্যাটারালি যাওয়ার জন্য আমার আছে এখন ইনফিরিয়র অবলিক এন্ড ল্যাটারাল রেকটাস, কিন্তু ল্যাটারাল রেকটাস এন্ড ইনফিরিয়র অবলিকের পুলের কারণে চোখ বারবার এই কোণায় চলে যাবে। চোখ বারবার এই কোণায় চলে যাবে। And they will give you the scenario that a person is trying to go downstairs and eye is drifting upwards. Eye drifting upwards. What's the reason? Whenever your eye drifts upwards, you get two answers, two things. Eye কেন upward drift করবে? কারণ inferior oblique pull করছে। Inferior oblique will make the eye drift upward and superior oblique damaged. এজন্য চোখটা বারবার ড্রিফট করছে উপরের দিকে। ঠিক আছে? Just this question you will get the same way. We will ask these questions in our exams and we have this. See. Where are the other options? Okay. Okay, here we have forgot to include other relations. ঠিক আছে? SO4, SOD. The answer will be trochlear. And about climbing, oh guys, I missed guys. About climbing stairs, and remember they will ask these questions. Going downstairs, তখন আপনার তাকাতে হবে নিচের দিকে। ঠিক আছে? So I will drift upward. নিচের দিকে তাকাতে যদি প্রবলেম হয়, superior oblique paralysis। ঠিক আছে? superior oblique paralysis and upward pull করছে inferior oblique। আর যদি আপনার আই deviated inferior laterally, that means already আপনার আই এখানে, আপনি আপওয়ার্ড ক্লাইম্ব করার সময় উপরে তাকাতে পারছেন না, সো superior oblique is working। কে কাজ করছে না? inferior oblique not working। ভেরি ইজি, জাস্ট দুইবার তিনবার করে শুনলে আপনার এটা ঠিক হয়ে যাবে। inferior laterally আই ডেভিয়েটেড, মানে এখানে, চোখটা এখানে, তার মানে সুপিরিয়র অবলিক কাজ করছে। যে কাজ করছে না সেখানে আইবল থাকবে না, সেখানে আইবল থাকবে না। সো ইনফিরিয়র অবলিক নট ওয়ার্কিং and all the extraocular muscles are supplied by oculomotor nerve. All the extraocular muscles supplied by oculomotor nerve. এটা নট ইম্পর্টেন্ট, রিডিং করতে পারেন, অথবা শুধুমাত্র আপনার নিউক্লিয়াসের পজিশনটা একটু পরে দেখতে পারেন। এই আর কিছু না, আর কিছু প্রয়োজন নাই। নাও উই হ্যাভ, আমরা আপনাকে ছোট ছোট করে বলে দিয়েছি যে এগুলা পরীক্ষার মধ্যে আসে কিওয়ার্ড, এগুলা সব কালেকশন অফ কিওয়ার্ডস। painful third nerve pulse. Painful third nerve pulse, posterior communicating artery aneurysm. Fixed dilated pupil, oculomotor nerve pulse. Direct light reflex lost, consensual light reflex present, afferent arc damage. Let me tell you about you don't really need that. You don't really need that. We have a video, we will give it. Okay, corneal reflex. Corneal reflex. ছোট করে বলে দেই আমি। This is our cornea. And what is afferent and what is efferent? This is our brain. কর্নিয়াতে আপনি যদি টাচ করেন, রিমেম্বার অল টাচ, পেইন এন্ড টেম্পারেচার সেন্সেশন ফ্রম ফেস is carried by trigeminal nerve. Trigeminal will take the input up to brain, so it will be afferent. Trigeminal brain পর্যন্ত সিগন্যাল নিয়ে আসবে, যে আসবে সে afferent, যে এক্সিট করবে সে efferent, or up to effector organ. Effector organ, very simple, very simple. So trigeminal, এটা আমার right eye. They just ask afferent arc damage or efferent arc damage. Okay, let me tell you. যে আসবে সে afferent, আর যে বের হবে সে efferent. Now they ask which one is the afferent limb, trigeminal, and যে বের হবে সে হচ্ছে efferent, and this is carried by facial nerve. Facial nerve will supply through temporal and zygomatic branch. Whenever you touch a cornea, the sensation comes to brain through trigeminal nerve. So afferent arc is done by trigeminal nerve and comes out from brain or exits from brain with facial nerve. So that's the exit branch, exit way, or efferent arc. Arc is nothing. Arc is just an arc. Efferent limb or efferent arc, same thing. Now it go to trigeminal and it go to temporal and zygomatic branch to orbicularis oculi and cause the eye to blink. This is corneal reflex. You touch cornea and your eyes blink. That is corneal reflex. Very simple. Trigeminal nerve carries the sensation, so it's the afferent limb or afferent arc. Facial is the efferent arc. Then here we have some questions. Here we have some questions. I have explained a lot. What do? You try to solve the question by yourself. If you find it hard, you watch this video, this portion again, then solve it again. Then if you are not understanding it, you post it to question posting. We will be there for you. Okay, let's talk about trigeminal nerve. What are the things you need to know? We have almost have had the most important topics. Right now we have some trigeminal nerve, facial nerve. These two important topics, and others are not so important. Okay, trigeminal nerve. Trigeminal nerve, all you need to know is 3 divisions and where do they exit from. Ophthalmic exits from brain with superior orbital fissure, maxillary through foramen rotundum, mandibular through foramen ovale. They don't ask about much about these things. They ask where does it come out, and about 3 nuclei. Where is the ophthalmic division of trigeminal nerve has nucleus, or what are the nucleus of trigeminal nerve? You just need to know 3 names. These 3 names and their location. Trigeminal nerve has 3 nuclei: mesencephalic, chief sensory, and spinal nucleus. Mesencephalic, chief sensory, and spinal nucleus. Know their location, very, very important. Then these things you can just give a reading, not so important. You can just forget it. Now, remember trigeminal nerve is, we have arch pouch cleft video. You watch it. Pouch cleft. Guys, anatomy is vast. Don't worry. Watch half and then study. Okay. Then most of the questions are from sensory supply. sensory supply. Trigeminal nerve questions are from sensory supply. You don't need to know all. Remember what we said. Remember what we said. Just know the supplies. Remember what we said. Above this area, everything is supplied by V1. Up to upper teeth, everything is supplied by V2. From front, not talking about side. Okay, let me tell you what are the important places you need to know supply. Other than that, you need to know nothing. See, you need to know which one supplies our lower palpebral conjunctiva. That means this one. This one is supplied by infraorbital nerve, maxillary branch. And infraorbital nerve comes through infraorbital foramen, and it gives supply to ala of nose. Ala means sides of nose. And it will give a labial branch and supply upper lip. Inside this infraorbital nerve will give superior alveolar branch and supply upper teeth. Just these things. Lower palpebral conjunctiva. Now, how smartly you can understand it, that's what matters. See, if you as all of these places are supplied by same nerve, so if you have pain in upper teeth, you can have pain in lower palpebral conjunctiva, you can have pain in ala of nose, you can have pain in upper lip only. Same goes for others. If you have pain in ala of nose, you can have pain in lower palpebral conjunctiva too, because the gora is same, the root is same. That's why pain here or any cut here or any damage here can cause pain in all these areas. All these areas. What are the areas of infraorbital nerve? Just remember this nerve from here. Upper teeth through superior alveolar nerve. Upper lip through labial branch. Ala of nose, no name. Lower palpebral conjunctiva, no other name. Just these four places. Now, tip of nose. They ask about tip of nose. It's supplied by external nasal branch from ophthalmic division of trigeminal. They ask about tip of nose. Then about lower lip. They ask about lower lip, and here your mental area. See, let me tell you. Here we have mandibular division of trigeminal nerve. Mandibular division of trigeminal nerve. Mandibular division of trigeminal nerve gives lingual nerve. Trigeminal supplies our touch, pain, temperature, sensation to brain. Trigeminal takes touch, pain, temperature, sensation from anterior tongue, anterior two-third. And mandibular branch gives inferior alveolar that enter mandible. Be very careful. আমি দেখাচ্ছি আপনাদেরকে. Enter mandible and gives lower teeth supply. It is called inferior dental or inferior alveolar. When it comes out, comes through a foramen, and it gets dental, gets mental, and this mental supplies lower lip and chin. What do we say? Just remember lower lip and under the area of lower lip. Just these supplies you need to know, and we have it all written here. We have it all. Here we have this thing. Just remember this. Tip of the nose supplied by mydriasis caused by external nasal branch of anterior ethmoidal nerve branch of nasociliary branch of ophthalmic nerve. Mydriasis caused by long ciliary nerve. It carries sympathetic branch. Here is our tip of tongue. External nasal branch of anterior ethmoidal nerve. Here is our intraorbital maxillary nerve branch. Then you can have this reading, nothing else needed, just reading, just reading. Then maxillary branch, just reading, comes out from foramen rotundum. And only one thing you need to know is from infraorbital nerve and the supplies I mentioned. Reading, just reading, আর কিছু প্রয়োজন নেই, just reading. Upper teeth, upper lip, supplied by superior alveolar labial branch. Everything we have written in our note. On the face, not important, just reading, just reading. And about upper teeth, that I said. Mandibular division, it has both motor plus sensory. It has both motor plus sensory. Remember this. Now, you need to know only two branches from mandibular nerve, which I said inferior alveolar and lingual. Two branches I have told you already, that is inferior alveolar and lingual. Remember, and this question came in exam and will come in exam. Lingual nerve does not enter mandible. What do they ask? They ask which nerve supplies lower lip entering mandible, enters mandible. They ask this question. That is inferior dental or inferior alveolar nerve. We have questions, we have practices, not a problem. Then it is derived from and it supplies all the muscles of mastication. 100% important. 100% important. You have to have these things at the tip of your tongue. All the muscles of mastications names are supplied by mandibular division of trigeminal nerve. Mandibular division of mandibular division of trigeminal nerve. And they will give you a scenario and say, they will give you a scenario like someone has fracture at angle of mandible. Now he cannot bite. From this stem, you will have questions like which muscle is responsible. Remember, from all of the muscles of mastications, two muscles are responsible for this: masseter and lateral pterygoid. Why? Because of their arrangements. Sorry guys, medial pterygoid. AJ. Because of their arrangement. See, these are arranged like this: masseter and medial pterygoid. Not lateral guys, medial. Not lateral. Masseter and medial pterygoid. These two are responsible. Any of these two you find in your stem, you select that and you pass the exam. Second question. Person cannot bite. So, which muscle will not be affected? Not be affected. See the difference between these two questions. See, specifically they are talking about biting here. That is, among these two muscles, one of them is injured severely. Now, here they are talking about all the muscles of mastication. So, they will give you all the names with one muscle that is not a muscle of mastication. Most commonly, they give buccal, supplied by facial nerve. So that will be your answer. Very simple. You will be understanding it soon and clearly. All you have to do now is study and memorize all the muscles of mastication so you don't forget it for the rest of your life, because you will have these questions in FRCS 2 and in paper 2 too. Okay, these things not important, not important, just reading, not important, just reading. Can, if you have time, otherwise just forget it. Just forget it. Here we have written down all of those: L of nose, upper lip, lower eyelid, upper incisor, upper lip, lower teeth, angle of jaw. Remember angle of jaw, angle of jaw, angle of mandible, same thing. Angle of jaw, angle of mandible, same thing. Supplied by greater auricular nerve. And area behind your caneloti, area behind your ear, is supplied by lesser occipital nerve. Area in front of your ear supplied by auriculotemporal nerve. Auriculo, here is your auricle, that's why it's called auriculo. And here is your temporal region, that's why it's called auriculotemporal nerve. Okay guys, then angle of mandible, angle of jaw, same thing. Like জ্ঞান, GAN, জ্ঞান। কেউ বেশি পণ্ডিতি করলে তাকে কি করতে হয়, তাকে কানের নিচে দিতে হয় যাতে একটু জ্ঞান হয়। সিম্পল এজ দ্যাট, সেম থিং। জাস্ট এই কথাটা আপনাকে বলবো যে কানের নিচে সেন্সেশন লস, হুইচ নার্ভ এফেক্টেড, জ্ঞান এফেক্টেড, মানে জ্ঞান কম, গ্রেটার অরিকুলার নার্ভ। ভেরি সিম্পল, greater auricular nerve. Now let's talk about one thing about this area. Here we have at the angle of mandible or jaw, we have parotid gland. Parotid gland is supplied by auriculotemporal nerve. Parotid gland is supplied by auriculotemporal nerve. What's the serial? Glossopharyngeal nerve takes parasympathetic fiber and gives it to otic ganglion. Otic ganglion takes the fibers and gives it to auriculotemporal nerve. So it can supply parotid gland and increase secretion, increase saliva secretion. So this is the ganglion. Before the ganglion, we have pre-ganglionic fibers, which comes from glossopharyngeal nerve. And after the ganglion, we have post-ganglionic fibers, which is taken by auriculotemporal nerve. Do the classes very carefully, guys. Very important. Then let's talk about ear. Okay, ear. This ear, and this question came, guys. See, inside your ear, only facial nerve is motor. Facial is motor. Facial is motor. Now, only inside the ear, above temporomandibular joint, inside the ear, we have a little supply of facial nerve at the roof of external auditory meatus. That's the only sensory supply from facial nerve. Facial nerve. Now, we need to know this. These are important. Just ear pinna supply. Sometimes they ask, important, very important. Lesions of trigeminal nerve. Now, you don't need to know all the details. We just taught you about corneal reflex. Just remember which one is afferent arc and which one is efferent arc. Then facial nerve. We know last time we explained a little bit. Let me tell you again, so you recap. Let's talk about facial nerve. Very important, guys. Every year question comes and every year they ask questions. See, we have here pontomedullary junction and facial nerve arises from here. And every nerve is a nerve bundle. We have different kind of fibers inside it. Now, what are the fibers we have inside facial nerve? First and foremost, we need to know the first fiber comes from superior salivatory nucleus. And here we have lacrimatory and salivatory fiber. Salivatory and lacrimatory nucleus. And this question came in September. And this is our lacrimatory nucleus. This is the geniculate ganglion. There is no nerve bundle, just it একটা কোনা genu. So false ganglion named geniculate ganglion. Lacrimatory fibers comes from salivatory lacrimatory nucleus and travels directly as greater petrosal nerve up to pterygopalatine ganglion, and from there goes to lacrimal gland and nasal mucosa. Whenever someone goes, we cry. So, pterygo, they ask about the ganglion. Pterygopalatine, which ganglion is involved if lacrimation is lost? Which ganglion is involved? Pterygopalatine ganglion. Here we have lesser petrosal nerve, not important, just remember before that. Greater petrosal nerve, GP. Which nerve is damaged if lacrimation is lost? Nerve, greater petrosal. Ganglion, pterygopalatine. Which nerve is involved if there is nasal congestion? Simple. Greater petrosal. Which nerve, which ganglion is involved if there is nasal congestion? Pterygopalatine. Then under that we have nucleus of Tractus solitarius. You don't need to know the name. Tractus solitarius. We have taste fiber coming from there, and salivatory fibers coming with taste fibers, because whenever we need to taste something, we need saliva. Anyway, now thing is that these two fibers comes out with, of course, lacrimal fibers, but lacrimal fibers leave them at geniculate ganglion. They enter middle ear cavity together, but somewhere around the line, they think where we are going, what is the meaning of life, why we are going. So they take a turn, both together, facial taste fiber and salivatory fiber. They are two friends taking a turn behind tympanic membrane, and it looks like a cord. This is called chorda tympani. The taste fibers are called chorda tympani, branch of facial nerve, comes out through petrotympanic fissure, goes to anterior 2/3 of tongue. Now, along the way, when they come out, they see someone going to the same place. Who is that? That is our lingual nerve. Lingual nerve carrying touch, pain, temperature fibers. So they go with that nerve, because at the same place, anterior 2/3, touch, pain, temperature is carried by lingual nerve, and taste fibers are carried by chorda tympani, branch of facial nerve. Taste. And the salivatory fibers with them goes to same place with lingual nerve, but they see some ganglions under mandible, submandibular ganglion, and they give supply to sublingual gland, submandibular gland, and increase the secretion. So I can taste food better. Simple as that. Now, the facial nerve proper, the main nerve, that is facial nerve, that motor fibers comes out from brain, goes up to geniculate ganglion, enters the middle ear cavity, and supplies a little muscle, that is stapedius, which controls the stapes so that it cannot, it controls the stapes so that it cannot vibrate too much. So the sound is controlled. Our sound manager, sound is controlled. If this is damaged, we have too much sound entering our brain, too much sound. That is hyperacusis. Now, after that, it comes, it goes down, and stylomastoid foramen, it comes out. It comes out at stylomastoid foramen and gives our desired branch, temporal, zygomatic, buccal, marginal mandibular, cervical. All of them are motor, controls muscle action. Controls muscle action. Zygomatic and temporal causes blink. Buccal and marginal mandibular controls smile. Cervical, not important, forget it. These are the complete facial nerve function. When you know all these, you will know just one basic you need. That is, they will mention these ganglion most commonly. If any damage after geniculate ganglion, after means distal to geniculate ganglion, all of the function will be lost. যেখানে ড্যামেজ হবে তার থেকে নিচে সব ফাংশন will be lost. Whenever there is a damage, all the function will be lost below the damage. Remember, below the damage. Just remember this and you will not make mistake with it. You will not make mistake at all. The rest is your job. You find out which function will be lost and which function will be preserved. We have a chart, not a problem. We have a chart. We have a chart, but you find out which function will be lost and which function will be preserved. And in revision, we will summarize in just one line, here, and like this. Okay, guys, branches of facial nerve, forget it. Forget it. Forget it. If you are in a, if you have more time, like 6 months, I would have told you to study a little bit, but right now, not important at all. Only important things. Only important things. Guys, see, about facial nerve lesion, remember, just one thing, either raise eyebrow. Just one thing. How do you differentiate lower motor neuron and upper motor neuron paralysis in facial nerve lesion? You tell the person to take your eyebrow up. If the eyebrow can go up, it's an upper motor neuron lesion of opposite side. If eyebrow cannot go up, that's a lower motor neuron lesion in same side. Just this one. Right now, nothing other than that is important. If needed, I will tell you later. Understand, 100% important. These are key points. These are key points, and you have to study it all. You have to study it all. ঠিক আছে, সব পড়ে ফেলবেন 100%, ফোটের আগায় এত কিছু after you understand, you memorize. Then auditory vestibulocochlear nerve, forget it. Just forget it. You don't study it right now, not important at all. And don't ask any question from me. Don't ask any question from it. Glossopharyngeal nerve, very, very important, guys. What are the important things about glossopharyngeal nerve you need to know? Remember its name, glossopharyngeal. That means it will supply the tongue and pharynx. And in pharynx, we have tonsils. Anything around tonsil, that is epiglottis, in front of epiglottis. Okay. Anything around the tonsil, the pharyngeal area, they will mention pharynx or pharyngeal area or tonsil. The supply, the touch, pain, temperature supply is taken by glossopharyngeal nerve. So if you have a tonsillitis, where will the pain go? As we have some supply in our ear through glossopharyngeal nerve, it will cause pain in your ear. And taste, okay, talking about taste. So I will talk about referred pain. So glossopharyngeal nerve, first thing you need to know, it supplies the tonsil and pharyngeal area. Number one. supply the tonsil and pharyngeal area. Pharyngeal area. Number 2, it. When you try to see the tonsil, if there is a gag reflex, remember gag reflex, touch, pain, temperature, sensation from posterior 1/3 of tongue and pharynx is taken by GP. So this is the afferent. This is the afferent to brain. Whenever you touch this area, touch sensation will go to brain with glossopharyngeal nerve, and brain will tell vagus to vomit. Simple as that. So it exits through vagus. So glossopharyngeal is the afferent limb and vagus is the efferent limb. From what? Gag reflex. Remember gag reflex. Second thing you need to remember. Gag reflex. Afferent limb, glossopharyngeal. Efferent limb, vagus. Very simple. Efferent limb, vagus. Okay, guys. Then হচ্ছে like what? Whenever you touch the tonsil or pharyngeal area, the touch sensation goes to brain through GP, and brain tells vagus to vomit. So exit route is vagus, efferent limb is vagus. You just know which one is the efferent limb. Then third thing, referred pain. I will tell you all the referred pain from this area at once. Epiglottis. Epiglottis, any cancer, any pain, any problem, epiglottis to ear taken by vagus. Tonsil to ear taken by glossopharyngeal. Very simple. Remember this. Remember this. Bas. You don't need anything else. Then parotid gland. Parotid gland. Here we have written it down. All the things. Remember carotid body. Why? এখন কেন এটা লাগবে না? কারণ হচ্ছে we will talk about carotid body a lot of times in our physiology classes. We will talk about glossopharyngeal. Right now, just remember these things. We have written it all down. Special sensory supply, posterior 1/3. Parasympathetic innervation to parotid gland up to otic ganglion. Remember, up to otic. It gives preganglionic fiber. Preganglionic fiber, not postganglionic. Preganglionic, guys. Then other things, just reading. Here we have mentioned efferent limb of gag reflex through vagus. Afferent limb of gag reflex through pharynx. We have this in our book, sensory function. Just reading. Just reading. Just the point I mentioned. Remember, other than that, reading. Nothing other than that needed. Parasympathetic fiber, auriculotemporal nerve. Reading. Vagus. Not important. Just remember larynx. We will talk about those. We will talk about those in our head, neck, and thyroid surgery. Remember larynx. All the muscles of larynx. All the muscles of larynx. Just remember, supplied by vagus. Supplied by vagus. Now, vagus, what are the branches of vagus? Remember, we will talk about that in head, neck, because it will make more sense. Here, nothing. Just remember 4th and 6th pharyngeal arch. 4th and 6th pharyngeal arch. Guys, sensory functions. Sensory, just reading. Special sensory, you can study it. Epiglottis, the taste you have when you have fever, it goes through vagus. The taste you have at the back of your tongue, it goes through vagus. Parasympathetic, it regulates the heart rhythm, lowers heart rate. Very simple. Other than that, you don't need it. You don't need it. Just reading, because it's you don't have. You just have 4 months. You don't need. In thorax, just reading. Not important if you don't have time. If you don't have time, not important. See, here auditory canal, you have it before. You have it before the ear auricle supply. So right now, not important. Visceral, reading. Not important. Motor function, remember larynx. Remember larynx, very important. Very, very important. We will talk about that. We will talk about that in head neck. Just remember larynx, supplied by all the muscles of larynx, supplied by recurrent laryngeal nerve, except cricothyroid, supplied by external laryngeal nerve. Right now, just memorize this statement. You know, still, just memorize this for now. In head neck, we will be able to explain it more. Then hypoglossal nerve, very, very important, guys. Very, very important. They will ask you, hypoglossal nerve, actually, you just need to remember all the extrinsic and intrinsic muscles of tongue is supplied by hypoglossal nerve, except palatoglossus supplied by vagus nerve. This is the first statement you need to study. Then about, they will ask you questions about carotid body tumor. Now, carotid body tumor, because here if you do an carotid end arterectomy, the closest nerve is hypoglossal. And hypoglossal supplies all the intrinsic muscles of tongue. Remember, all you have to know, number one, before carotid end arterectomy, you must counsel the patient about tongue deviation and vocal cord paralysis. Why? Hypoglossal nerve supplies all the muscles, and among them genioglossus forms the main bulk of your tongue. Genioglossus pushes your tongue outwards. Both sides genioglossus pushes your tongue outwards. If I tell you to put your tongue out, if we have carotid end arterectomy on right side, left side, and hypoglossal nerve is here, if we somehow damage this nerve, this genioglossus will be paralyzed. I'm marking it red. Now, when I tell the patient the next day, put your tongue out, that person will try to push his tongue through both genioglossus, GG, but this one is paralyzed. So this genioglossus will push the tongue hard, and because there is no balance from this side, this tongue will come out this side. This tongue, এই পাশের জেনিওগ্লোসাস প্যারালাইজড হওয়ার কারণে, এই জেনিওগ্লোসাসের যে পুল, সেটার কারণে টাং সোজা বের না হওয়ার কারণে, যেহেতু দুই পাশ থেকে পুশ করলে টাং সোজা বের হইতো, কিন্তু এপাশ থেকে কোনো পুশ নাই, এই জন্য টাংটা বাঁকা হয়ে বের হবে। এবং যেদিকে বাঁকা হবে, কোন দিকে বাঁকা হবে আমরা দেখতে পাচ্ছি, যে পাশে ড্যামেজ হয়েছে, that side will be indicated. Tongue will be deviated to ipsilateral side to damage. Ipsilateral to damage. They will ask you this question. Guys. Answer cervical is reading, not important. This is the tongue deviation picture. Genioglossus. Right side carotid end arterectomy, right side damage, and right side genioglossus paralysis. Spinal accessory nerve. Spinal accessory nerve is in posterior triangle of neck. So we need to have head neck class before that. Just give a reading. Nothing else is important. Blood supply of the brain. I have already told you about that. If we have an aneurysm in posterior cerebral artery, that is here, posterior communicating artery, posterior cerebral artery, or anterior inferior cerebellar artery, we can have, guys, sorry, we have this thing. I hope I will mark it later. Anyway, we have an aneurysm here or here. Our oculomotor nerve here will be damaged because এটা খুবই চিপায় আছে. We can say it. And superior cerebellar, guys, a minute. This one, posterior cerebral, superior cerebellar. ঠিক আছে, these are the three arteries. I have already shown you, no need to show again. See, we need internal carotid artery. Guys, internal carotid artery, just remember, you don't need all these, just forget it. Just remember one thing. Upon, just remember these two things: communication. Continuation is middle cerebral artery and branch is anterior cerebral artery. You have this mnemonic here. If you want, you can study it, but not important at all. Just remember this one. After, upon entering cavernous sinus, after entering from cavernous sinus, this is our cavernous sinus. After entering brain from cavernous sinus, after exiting from cavernous sinus, the first branch is ophthalmic artery. First branch after cavernous sinus. Just remember this one, ophthalmic artery. And remember another thing, যে আমাদের নেকে কোনো শাখা নেই, আমাদের নেক এ কোনো শাখা নেই, no branch in neck, no branch in neck. Then about stroke, guys, don't worry about stroke at all. Just remember the things I tell you. Just remember the things I tell you. Just remember, they will give a long scenario. Just remember these things. They will not ask you details. They not ask you details. They will just ask you anterior cerebral artery stroke. Just they will mention paralysis. If they say leg is paralyzed or leg is more weak than other part of the body, that's anterior cerebral artery stroke, ACA. Simple, just this thing. Every time you will answer it right in 100% cases. Just see if legs are more weak or legs are paralyzed. If they say aphasia, hand paralyzed, or upper limb more weak, or hands are more weak, or aphasia, or speech abnormality, plus homonymous hemianopia. Either homonymous hemianopia will be present or not. If homonymous hemianopia is there, you will see, I will talk about that, if there is speech abnormality or hand weakness. Okay, see, if your question have hand weakness or speech abnormality, that's middle cerebral artery stroke. If your stem has vision problem, balance problem, nystagmus ataxia, and neglect, just neglect vision, balance, or nystagmus ataxia, upper limb, lower limb, nothing mentioned, upper limb, lower limb, nothing mentioned or unclear, but vision problem, nystagmus, that is posterior cerebral artery stroke, nothing other than that, for MRCS part A. Then now let's talk about homonymous hemianopia. You will have confusing question with it. If your question has homonymous hemianopia সাথে speech abnormality, that is MCS stroke. If your question has homonymous hemianopia with nystagmus ataxia, but there is no speech abnormality and no upper limb weakness, that is posterior cerebral artery stroke. If your question has only homonymous hemianopia and nothing other else mentioned, or vision problem only, that means there is no speech abnormality. If there was, they would have mentioned it's PCA stroke. Simple as that. Posterior inferior cerebellar artery, in fact, very, very important. Remember ptosis, meiosis, and anhidrosis. Horner syndrome. Ptosis, meiosis, anhidrosis, plus ataxia, dysphagia. These are three. Okay, we need to guys, posterior inferior cerebellar artery stroke is very important. Remember Horner syndrome. If any of the presentation I mentioned above is there, but with that you have Horner syndrome, that's PICA. Nothing other than. And here we have attached the image of arteries involving the nerves. The one I showed you. These are pictures for your, so your eyes can generate a memory. And we have this on our new edition anyway, and in our PDF too. Which nerve will be affected first in the anterior inferior cerebellar artery infarct? Remember, facial. What did I say? What did I say? Facial and vestibulocochlear. 7 and 8 is common in both AICA and PICA. For AICA, add 6. For PICA, add 9, 10. Very simple. Which forms the posterior lateral boundary of circle of Willis posterior communicating artery. Then cavernous sinus, very important. And I told my candidates before the exam, remember, if cavernous sinus, this is the floor of cavernous sinus, and the main content is internal carotid artery and abducens nerve. Nerve number 6, abducens nerve. Others are on lateral wall. If there is a thrombosis, which nerve will be affected? Abducens nerve. If there is a cavernous sinus problem, which nerve will be affected? Abducens nerve. That is nerve number 6. Others are on lateral wall. They are not in the floor. They are not the content. Only content is this one. Others are lateral wall content. And this September, this question came exactly as we said. So you will have a lot of questions from only this class. Study it real well. Okay, guys. And contents of cavernous sinus, lateral wall contents and floor content, everything is easy. What did we say in superior orbital fissure? In front of cavernous sinus, we have superior orbital fissure. So just write 3, 4, V1, V2, 6. And from these, when SOF, superior orbital fissure, is asked, just remember here we don't have this one. Others we have 3, 4, V1 and V6. 3, 4, 5, 6. 3, 4, 5, 6. V1 and V6. This one. And in cavernous sinus, we just add V2. 3, 4, 5, 6. V1, V2, 6. Simple. In cavernous sinus, 3, 4, 5, 6. 5, 1, 5, 2, 5, 6. 3, 4, 5, 1, 5, 2, 6. Simple. And in SOF, just V2 bad. Simple as that. These are the lateral wall contents of cavernous sinus. Very important. এখানে আমরা লিখে দিয়েছি lateral wall content, main content বা floor content. Floor content. Any thrombosis, which nerve will be affected? This one. This one. Okay. And most common organism is Staph aureus. Very, very easy. Very easy. 100% important cavernous sinus. Just study it. Just study it. Very simple. Then dural venous sinus. Very easy. See, superior sagittal sinus, the one that is superior. That the one that is above fox cerebri. Fox cerebri. And at the free edge, we have inferior sagittal sinus. At the free edge, we have inferior sagittal sinus. Now, they will drain into straight sinus. Inferior sagittal sinus drains into straight sinus. And ultimately, sigmoid sinus and internal jugular vein. Remember, sigmoid sinus spreads infection. I will tell you in detail. Sigmoid sinus spreads infection from ER, middle ear. From middle ear, infection spreads through sigmoid sinus. Anyway, we will talk about that. We will talk about scalp layers in head neck class. Okay, guys, we have just finished neuroanatomy. And about spinal nerves. Oh, guys, sorry. We just talked about central nervous system. About spinal nerve, there are something you need to know. Just something. Just something. Right now, you don't need to know anything. Just something. When we study all the anatomy, we will talk about these dermatomes and these. And right now, just remember, where does it end? Cauda equina. Cauda equina starts from lumbar 1. In adult, up to L2. Spinal cord ends or conus medullaris is situated at L1. Spinal cord end is the cona or conus medullaris, that is situated at L1, and cauda equina starts from after L1 and we call it L2. Simple as that. And the best place to draw CSF is in between L3 and L4, and the landmark is iliac crest. Iliac crest. The covering after spinal cord is, we all know, three layer of meninges: dura, arachnoid, pia. Pia matter is leptomeninges, like visceral pericardium, and let me draw it, guys. Let me draw it. This is your brain. This is your brain. Pia is leptomeninges. Pia is just visceral peritoneum that is so attached that that's not separated. That is not separated. Arachnoid is above this layer. This is your brain matter. You can't separate pia matter. Arachnoid has this thing. Arachne means spider. That is makorsha, whatever you say it, makorsha. And it has 8 legs. And this is your arachnoid matter, like this, above brain. And we have bridging veins here, bridging veins here. And above that, we have dura. Above that, we have dura matter. And above that, we have epidural space. Okay, guys, we will talk about scalp layers. We will talk about scalp layers. Then we'll talk about these brain layers. Very easy. Dura matter, arachnoid matter, pia matter. Arachnoid matter contains our bridging veins. Arachnoid matter contains our bridging veins with brain. And under the arachnoid matter, we have subarachnoid space. You will get this will get complicated because a lot of things are related to it, like head neck surgery and others. Just remember dura, arachnoid, and pia. We will talk about that later. And this is our spinal cord, brain matter. We have pia matter attached to it, and around it we have arachnoid matter, and in subarachnoid space we have CSF. And above arachnoid matter, we have dura. We have dura matter. CSF is here in arachnoid space. And this is our dura matter here. This is our dura matter here. Now, the venous plexuses are outside of the dura. Outside of the dura. Remember, all the blood supply, all the blood vessels of brain is situated in subarachnoid space, floating in CSF. Now, these are outside vertebral venous plexus. We'll talk about that. We will talk about that. And this is spinal cord. And look at this ligament. Look at these ligaments. Look at these ligaments. These are dentate ligament. These are dentate ligament. What is their job? Their job. This is our pia matter. This is our arachnoid matter here under dura. And this is our dura matter. Their job is to hold spinal cord, attach spinal cord with dura matter. With dura. This is their job. Remember. This is their job. Okay. Cauda equina, we will talk about these things later. You just need to know the anatomy right now. You just need to know the anatomy right now. Okay, guys, thank you. We will just study this and study half. We will start our head neck class. on our given date and the same time. Okay, guys, watch half up. Don't take too much stress. Have fun, guys.